Great. Tammy, please go ahead and feel free to introduce yourself, and you may start sharing your screens.
Thanks, Sumia. Hi, everyone. Nice to see everybody today. My name is Tammy McLean. I am a research associate at Women's College Hospital, both with the Center for Wise Practices. Oh, sorry, Sumi is looking at me. Should I be recording already, or sharing my screen rather?
Oh, no, please go ahead. You can share. You can feel free to introduce, and then you can share. I was just staring at the participant list. It's all good.
Okay, great. So I'm a research associate at Women's College Hospital, started with the Center for Wise Practices in Indigenous Health, as a health system, CIHR Health System Impact Fellow, and have transitioned into a research associate role. And I'm also working with O'Neill at Weave, who I see here. Hi, O'Neill, and as a research associate there as well. So, but this work that I'll be presenting today is sort of, it's a few years ago that we sort of undertook this environmental scan, and it was part of my work as a postdoctoral fellow at the Atlanta School of Public Health. So, I'll get into that shortly, but I just wanted to say I come to this work as a former registered nurse, and have worked in health systems across Canada, up in the northern Northwest Territories in a small Indigenous community, and in Australia and the United States. So that early clinical experience that I had really sort of set me on a trajectory of health equity, recognizing that health systems don't work for everybody, and some better than others, of course. And so that's a little bit about how I come to this work, and I guess set the stage for my perspectives and interests in health systems research. So I'll just share my screen then.
Sounds great. And I'll keep an eye on the chat, and if there are any hands, in case you're not able to see that.
Excuse me. Thanks, Sumia. So today, as I mentioned, I'll be presenting the results of an environmental scan that was undertaken. It was really to inform an anti-racism strategy for an Ontario health team, which was formerly the Toronto Central Local Health Integration Network, now Ontario Health. So first of all, I want to take a step back and just acknowledge my personal accountability in doing this work. And really, I recognize myself as a white occupier to these lands, and I acknowledge the ongoing dispossession that Indigenous peoples face and the many generations of harm caused to their cultures and to their ways of life. I also acknowledge my unearned white privilege, and I commit to learning about the untold history of Canada and to supporting the leadership and efforts of Indigenous peoples to reclaim their inherent rights as outlined both in the Canadian Constitution under Section 25 and through various international human rights agreements. So as I mentioned, this work was really about understanding what sort of frameworks, guidelines, and toolkits that can be sort of pulled from the literature on learning health systems to advance health. And in this case, for our project, it was to address anti-Indigenous racism. And so I really want to kind of frame that this work really comes from an Indigenous perspective of reviewing and critiquing these guidelines. And some of them work really well, but some of them, as we went through the sort of literature, we realized that there's some limitations to how those might apply to Indigenous health. So unlike the two previous presenters on learning health systems as part of this seminar series, really amazing experts on learning health systems and have spent many years doing this work. This was sort of a dip in a bucket of learning about learning health systems and all that's involved. And so my knowledge is very narrow, but I do bring an Indigenous lens to this work, an Indigenous perspective through my colleagues at the Atlanta School of Public Health. And really, I hope, because many of you were learners as well, maybe some of this these early learnings on how to sort of get a learning health system up and running might resonate with folks here. So the concept of a learning health system was initially developed in 2007 by the former Institute of Medicine, now the National Academy of Medicine. It's really sort of it was built for an American health system context, and you might see the implications of some of that in sort of the frameworks that and tools that I discussed. And so the core principles really of a learning health system is that they're person-focused, privacy is respected, inclusiveness is valued, as well as transparency, accessibility, adaptability, governance, cooperative and participatory leadership with scientific integrity and value. So lots going on there. These are, this all started, this concept of a learning system started as an ideal of what health systems should work towards. And I think it's been sort of evolving towards that. But I feel like in many ways we're in early stages, given the state of the literature. And really the concept of the learning health system has gained traction internationally for its promise of accomplishing the quintuple aim. It was initially the quadruple aim, but recently health equity was added to it. And so the 5 sort of aims are to improve the individual experience of care for patients, to improve the health of populations, to reduce the per capita costs of care, to improve the experience of healthcare professionals, and then of course to advance health equity. And so you'll see on the right side of the screen at the bottom there, the learning cycle. And this was discussed in some of the prior presentations as well, so I won't get into it too much. But essentially you have sort of 3 kind of stages happening. First of all, you have data to knowledge, and that's really about gathering data and gleaning knowledge from that data. And then the knowledge to performance is applying the knowledge to implement change and transform healthcare through individual training, team training, implementation of new processes, integration of new technologies, and changes to the processes and environments of care. And then finally, the performance to data is the lessons of improved performance that are used to inform and refine the next cycle of gathering data. And sort of this learning cycle continues repeatedly, and it could go ad infinitum as sort of technology changes and as health sort of outcomes of patients improve over time or new health issues emerge. So in terms of bringing an Indigenous lens to this, I just want to put forward that I recognize and my teams recognize Indigenous peoples as rights holders. And this goes back to the British North American Act prior to the formation, or which is part of the formation of Canada in 1867. And this was really about establishing federal jurisdiction over First Nations health. So that was taken into account right at the beginning when Canada was formed as a country. And then following that, the Indian Act was a piece of that as well, and it involves the provision of healthcare. But the language is really unclear in the Indian Act as to who is responsible, and it does not necessarily give legislative authority to the federal government. So some conflicting messaging there between the British North American Act and the Indian Act. And today, healthcare for First Nations people falls under the 1939 Supreme Court ruling that confirms the federal government of Canada's legal responsibility for the health of First Nations and Inuit people. And Métis people do not fall under this legislation. They were not considered beneficiaries of these services. In 1982, the Canadian Constitution Act, this came much later. This actually clarified some things by recognizing and affirming the treaty rights of First Nations, Inuit, and Métis, including the right to govern themselves in relation to matters that are internal to their communities and integral to their unique cultures, identities, traditions, languages, and institutions, and with respect to the social relationships to their land and resources. So that can be viewed fairly broadly because it is broad language, and certainly health would fall under that. So today, modern treaties and new self-government practices are creating new opportunities for Indigenous peoples in Canada to engage in health policy and service delivery. And an example of that is the First Nations Health Authority in British Columbia that's established a tripartite agreement with both the provincial and federal governments to take over all, funding. Well, they receive the funding, but to take over all the sort of direction and management and government of health for First Nations in British Columbia. And I understand other municipalities, including Halifax, are sort of just starting down that journey themselves. So I'd be remiss to not mention the terrible history that Canada's health system has with Indigenous peoples across the country. And some of you may know about the sort of the residential school system, but certainly that started around the same time as the Indian hospitals, which began in the early 1900s and ended in the late sort of around the 1980s. And it kind of went hand in hand with the residential school system. And it was really racially segregated healthcare, which operated as general hospitals. But really it involved enforced hospitalization of people, which was initially rationalized as, forcing people to get treatment for TB and increasingly among Indigenous peoples living on reserve who were much higher risk because of the poor conditions of housing that wasn't being kept up by the federal government on reserves. But then there was also maternity and pediatric wards in some of these Indian hospitals as well. And patients were physically restrained to prevent them from leaving. And there was often experimental treatments undertaken on Indigenous patients that were often painful and underwent disabling experimental surgeries. They were chronically funded, overcrowded, and staff often were undertrained and under-licensed. And across the country, there was about 29 at sort of the peak of that era. In addition, there was what some refer to as starvation experiments that happened in the 40s and 50s. And these were actually led by the federal government themselves, which is now Health Canada. It was conducted on more than 1,300 Indigenous children from residential schools across Canada, and many resulting in death. And then, of course, we know today many instances of anti-Indigenous racism that has been documented in health systems across Canada. So on a lighter note, the background of this study was essentially this work was undertaken as part of Ontario Health strategy to address anti-racism more broadly. There was an anti-Indigenous component as well as an anti-Black racism component. And so Dr. Angela Masker-Pringle, who's the Indigenous lead at the Delana School of Public Health, was consulted for this, and I had the privilege of sitting on the committee meetings. And so really what Ontario Health was trying to do is to understand what an anti-Indigenous racism component of that strategy would look like. And so our team was sort of tasked with running lots of searches and putting together various things for this resource, and the developing a learning health system and sort of tools, frameworks, tools, and trainings to be able to enable health system actors to try to work towards putting a learning health system in place. And so essentially that's what we did. And at the time we were so rushed, we were on short timelines with the government. So we didn't really have a chance to critique those tools, trainings, and guidelines at the time. And so since then we've published the paper, and as part of the paper, there is more of a critique that has been included in that. So essentially it was an environmental scan that we ran, and we were looking specifically for sort of tools that folks could sort of understand in simple terms to start building from the ground up components of a learning health system. And so we found 37 resources during this scan, and that's what I'll be presenting today, a high level overview of each one of those. So in terms of the frameworks, guidelines, and toolkits, this was sort of the biggest sort of pool of resources that we found in the literature. And we drew from literature from not just in Canada, but from across the world. The UK is a big player in learning health systems, obviously the US, but other countries as well, including Japan and others. And so the first sort of component of the learning health system from our perspective of the framework is data and evidence driven is the objective. And so really looking at the frameworks that we found, we're really looking at data reuse and sharing across jurisdictions. And so the first sort of framework we found was called the Safe Fives model, the Five Safes model. And this was developed originally in British Columbia and recently revised beyond its first iteration. And so this model provides guidance on private and safe data sharing across jurisdictions and organizations. And it refers to the five safes are referred to as safe people, safe projects, safe data, safe settings, and safe output. And so, a lot of these data principles probably to a large extent, especially in Canada, perhaps apply already, but maybe some others not so much. So, only authorized individuals can access the data. Data projects must be in the public interest. Certainly that's the case in Canada. The US is a bit different with their private system. Outcomes should avoid harm while carrying public benefits. Data must be anonymized and used only by researchers from public institutions in a controlled and secured environment, and using the right technology to integrate data safety and additional protection of privacy and research outputs. And so while this looks great, it really overlooks from an Indigenous perspective the OCAP principles of ownership, control, access, and possession. And so it fails to consider Indigenous data sovereignty and these principles. And in doing so, it also overlooks Canada's colonial history and would result in rights violations against Indigenous peoples. So perhaps this could be revised as many of the items in here to consider those principles. So the second framework we called is that we found is the distributed approach. And it really aims to provide the guidelines on implementing data systems. And it involves the creation of networks of resources, as well as locally processed sensitive patient data to ensure it's private and secured. And then it can be shared across collaborators for analysis. The centralized database architectures use anonymous data from collaborators, which accumulates in a repository and ultimately provides data analysis, visualization, and other functions. And so also an interesting framework and could be useful for developing data systems in a learning health system. But again, same critique as the previous framework is that it does not apply to Indigenous peoples, doesn't consider data sovereignty, and overlooks Canada's colonial history. So the third data and evidence-driven framework we found was it was an interesting sort of toolkit developed by the Michigan Surgical Quality Collaborative, and it was based on a surgical quality improvement, obviously. And so, I mean, this could possibly be adapted to other sorts of surgery but using the processes. And the aim is really to improve the quality of data collected in a learning health system. And it addresses commonly asked questions and assists healthcare organizations in starting a learning health system collaborative model. So essentially it provides knowledge and practical information on how to develop staffing, find resources, plan and organize, and satisfy legal and regulatory issues surrounding collection and analysis of data. And the toolkit outlines an allocation of consistent data codes for clinical information, which could be quite useful, such as disease names and procedural terminology. So that was on that image on the right is the main one of the key learning health system sort of model images, which I referred to earlier, applied to the surgical quality improvement toolkit. And so once again, as with the data from the previous, the two model or frameworks shared, it doesn't consider Indigenous OCAP principles, and therefore is not considered safe for Indigenous patients and their data. So the next component that we'll be looking at from a frameworks perspective is patient-centeredness. And so the frameworks that we found do provide some potential to facilitate a holistic, community co-developed and culturally safe learning health system. So the first framework is called a patient engagement framework. And this was actually developed by, some of you may be familiar with, this is CIHR's SPORE from 2014, their document framework. And the aim is to achieve patient-oriented, transparent, and relevant health data. And it was created in consultation with Indigenous stakeholders, which for us is a big 2 thumbs up. We know that the data the rules around data collection and management are going to take into account the rights of Indigenous people as stakeholders. And it recognizes patients and active partners in health research and pursues an inclusive, supportive, mutually respecting, and co-building environment for health research. So in this respect, it does have that potential to facilitate a culturally safe learning health system. And the second patient-centered framework is the PEDAL framework or PEDAL framework. I'm not sure exactly how it's pronounced. And this one as well, like the previous one, does have potential to create a culturally safe framework for Indigenous patients. The aim of the PEDAL framework is to advance health equity with the learning health system through maximizing stakeholder engagement. And so the core components of this framework include prioritizing health equity, engaging in community, targeting health disparities, acting on data, and learning and improving. So it sounds pretty good. It provides practical and actionable steps that prioritize health equity, social determinants of health, community engagement, sustainability, and technology. So it does integrate equity with a focus on non-Indigenous social determinants of health. So that was the one thing that we flagged. We know that there are many Indigenous specific social determinants of health that don't fall in that sort of general WHO, and Canada has provided their own sort of interpretation of the social determinants of health for Canada, but we do need to be considering colonization and systemic anti-Indigenous racism as two key determinants of health in Canada. And the third patient-centered framework, excuse me, is called the Continuum Model for Community Engagement. And this model helps to distinguish between different levels of community engagement in the context of an expanding healthcare system, which it refers to as a continuum of engagement. And at one end is the traditional research with no community engagement. At the other involves participatory models of engagement. And at the other end is the participatory models of engagement with the endpoint where research is really initiated by community. So that's quite a big shift, and you've got various probably points along the middle of that spot as well, but between those along that spectrum. But the idea of having research initiated by community is a key sort of a key characteristic of this particular framework. And of course, this has the potential to facilitate a holistic, community, co-developed, and culturally safe learning health system. The only piece here is, again, just like the one before this, the PEDAL framework, it also looks at non-Indigenous social determinants of health. So one strike down for that one from an Indigenous perspective, but otherwise this could be, if the sort of Indigenous specific determinants of health were considered, this could be evolved quite nicely. And sorry, I think this was a 4-1 here. This is supposed to be number 4 under cultural and competencies enabled. So the fourth framework for this piece of the learning health system is a quality improvement project management tool. And so this is from the Institute for Healthcare Improvement, with which some of you may be familiar with. They do a lot of really interesting work in the US, and are always seem to be publishing things, resources for adopting learning health systems. And so this project management tool, it's fairly basic, but I mean, it does describe strategies to effectively manage quality improvement projects, specific ideas to try within each strategy, and a workspace, offering some workspace to note steps to implement the strategy. So, it might provide some interesting directions on what to be considering in developing your quality improvement project. So it highlights strategies to front load the work, focus on learning and not perfection. We're all, this is a process and not an end goal, developing a learning health system. And so literally not just to set one up, but to keep it functioning. So if you're perfectionists, you might want to reconsider, like I am, you might want to reconsider working on learning health systems. And it's also, it tries to make it easy, build a big tent sort of effective teams with resources, and make sure you have an end date to these sorts of things. Otherwise they could go on forever. And then of course it weaves 4 themes throughout this framework, or tool, and this, they call it a tool, and its practical actions within each strategy are provided to avoid problems before they arise. And the second framework to support the culture and competencies enabled component of the learning health system is a quality improvement essentialist toolkit. And again, it's another output from the Institute for Health care improvement, and pretty simple to use, but gets you thinking in the right direction. And the aim of this is to include the needed tools and templates to launch a successful quality improvement project and manage performance improvement. And it includes 10 quality improvement tools, a short introduction or description, and provides some examples and blank templates that you can use. And it uses this sort of plan, do, study, and act sort of stages that reinforce each other through the process. This essentialist toolkit also includes causes and effect diagrams, figure models and effects analysis, run charts to monitor performance over time, and it has various worksheets, including this sort of rapid cycle testing for learning health systems. And then there's this interesting tool for the culture and competencies enabled component. This was developed by Northern Health in BC. And it's quite interesting. It's really the purpose of the tool was to provide guiding principles to support the operationalization of culturally safe health services and health outcomes for Indigenous people specifically. It includes 4 decision-making tree designs to guide users and assess initiatives for the appropriate and respectful inclusion of Indigenous peoples. So it's really about how do you engage community. The accountability mechanisms are there to ensure Article 24 of UNDRIP is implemented. UNDRIP is the United Nations Declaration on the Rights of Indigenous People, and BC has been the only jurisdiction in Canada that has actually put it into law with their own piece of legislation, which is referred to as DRIPA. Yeah, and so we've got a lot to work to do here in Toronto, here in Ontario. And so this sort of the Article 24 of UNDRIP is they want to ensure that it's implemented, and this would include ensuring, excuse me, the right to traditional medicines, to maintain their health practices, and to access without discrimination all social and health services. And then the final culture and competencies framework that we found was called a Health Equity Impact Assessment Workbook. And this is actually from Ontario. It's quite dated, and you can tell by looking at the document, but it does have some interesting ideas as well that can get you thinking in the right direction. The aim was to identify unintended potential health impacts of a policy, program, or initiative on made vulnerable groups within the population. And the overall goal of this workbook is to reduce health inequities due to barriers in access to health services and to ultimately improve health outcomes. So this workbook can be used to review funding applications for health services, but also to retrospectively review, evaluate, or decide whether to expand services. And the assessment requires community engagement and consideration to the social determinants of health beyond the health sector and how they influence health outcomes. So a thumbs up from an Indigenous perspective, taking into account the social determinants of health as long as they're considering specific ones for Indigenous peoples. And so now we've gone through the cultural and competencies enabled and the data and evidence driven. And so now we're moving to looking at supporting systems, learning health systems themselves. And these are where they start to get a little bit more technical. So this particular framework, it really addresses, it's a terrible name, but it addresses information, technology, processes, objectives, staffing, management, and other. And the other is, I guess, any other factors that need to be considered, but also looking at the barriers, benefits, and facilitators of all of these elements. So lots going on here in this. And of course, if you're looking at supporting a learning health system, there's lots to take into account. So it can help you start to think about all the different pieces and how to be thinking about them. So the aim is to identify the systemic barriers and facilitators to achieving high value care with the learning health system and to evaluate gaps between design and implementation. And of course, that IT refers to information and technology, and then you've got processes and objectives, skills and management, other resources and constraints, and then the barriers, facilitators, and benefits. And the successful adoption of a learning health system, according to this framework, should take account of the proposed framework, especially with respect to its focus on removing barriers that have the most impact. So because this was such high level, we didn't really, it's really hard to know. It's more the minutia that we would critique if from an Indigenous lens. So, you know, I think it's more the devil is in the details, which at this level doesn't really provide a lot of. So hard to critique this framework. And then another framework from BC is the Academic Health Sciences Network Partner Tool. This was developed a few years ago, and for the life of me, I found a description of it, but couldn't find the actual the framework itself. I don't know if BC Academic Health Sciences Network has been collapsed into their current funding new structure. But anyways, this essentially, if you can find this online, as we did when we initially ran the scan, its aim is to measure, map, and monitor patient-provider relationships to identify strengths, gaps, and strategies for improvement. And it also has the capacity to support patient autonomy and monitor cultural safety within the patient-provider relationship, which is a good thing from an Indigenous perspective. The BCAHSN has provided an action plan for other health other health systems interested in developing and implementing a learning health system within their own jurisdiction. And then finally, from the system supported end, these architectural frameworks really aim to identify various learning health system dimensions and provide a critical understanding of the types of decisions that need to be made within each dimension. So there's an image on the top right of the screen there that sort of breaks down the pieces that are involved in this. In these frameworks. And so these are the sort of 5 dimensions of the framework, and they support the analysis of learning health systems and how their outcomes and allow their outcomes to be simulated, and they're therefore acting as a pre-implementation sort of decision support tool that can identify potential barriers and enablers of system development. And the proposed architectural framework is comprised of the 6 decision layers that model these dimensions. So from our perspective, it really takes a very highly biomedical approach without consideration of the social dimension. And so it contains only the relationship component without consideration of the power imbalance between whoever's data is being used and the user of the data. And then we also found frameworks that weren't just at each component within each component of the learning health system at that level. We also found learning sort of frameworks that apply to the entire learning health system. And so the learning health communities was a really interesting sort of framework that we found that was published not too long ago. And its aim is to identify unintended potential health impacts of a policy, program, or initiative on made vulnerable groups within the general population. The authors identified sort of what they called an equity relationship gap in many learning health system frameworks. And so they really wanted to address that, and they set out a high-level directive for developing and implementing a learning health system, which really centers community engagement to achieve a learning healthcare community instead of a learning healthcare system. So there's a need for trust and co-development for the learning health system to meet needs of made vulnerable individuals and communities from their perspective. And this is a group in the US, if I'm not mistaken. Another sort of learning health system level framework is this ethics framework done by Fadden and team, and it's a bit, it came out in 2013, so a few years ago now, and it aims to identify unintended potential health impacts of a policy, program, or initiative on made vulnerable groups within the general population. And so like the previous building health communities, the one I just presented, that this similarly discusses sort of obligations for a learning health system, which they call the 7 fundamental obligations, including identifying those responsible and required activities to fulfill those obligations. So provide some good structured direction on how to go about doing that. And so they sort of lay out respecting patients' rights and dignity, providing optimal care to each patient, addressing unjust inequities, avoiding imposing non-clinical risks and burdens on patients, and improving the quality of clinical care and healthcare. And another learning health system level framework is this sort of logic model done by Ellen and team. And its aim is to identify essential learning health system inputs provide transparency to learning health system activities, and define key outcomes to evaluate learning health system processes and impact. And based on sort of 7 existing frameworks and models, it includes, based on 17 existing frameworks and models, and it includes 24 constraints, which is, they've come up with quite a comprehensive sort of framework to consider. Each is described and examples are provided to make them for evaluating a learning health system. And so people and partnerships is identified as essential to learning health system, which is a good thing from our perspective. It emphasizes diversity in skills and backgrounds among team members, and also emphasizes key stakeholder relationships, including with patients, both internal and external to the organization. So again, this one also doesn't really take into account relationships are good, but we also have to consider how those power imbalances are managed in those relationships. So we've gone over some frameworks, and I know this is a lot of information. It's sort of meant to be high level to give you a sense of the literature out there. So next I'm going to look at training. The frameworks were by far the most resources that we found, and the trainings, as you'll see, are not numerous. So and in fact, we didn't find any for patient-centeredness. But you know, our team sort of was of the mind, and this is consistent in the learning health system literature, that capacity building should involve supports for patient partner participation in research and quality improvement projects, training to improve patient-centered care and facilitate patients as co-researchers. We view as imperative for a successful and effective learning health system, but we found no training programs for patients as co-creators and co-researchers in health that address specifically effective, safe partnering in a learning health system. So addressing that power imbalance that I mentioned that was missing in some of those frameworks. And so we found one sort of, I guess, resource that could be used as a training for the system-supported component of a learning health system. And this was the competencies, sorry, I'm just kind of trying to remember what this one was. So it's to support value-added decision-making in a learning health system, researchers and employees must have information to develop or expand training programs to develop for learning health system researchers and patient researchers. So training can follow the learning health system competency appraisal inventory tool, which is what you see on the right there. And so this outlines quite a few competencies and sort of whether or not they've been met, creates a tool for tracking. So it identifies training gaps across the respective levels of a learning health system. And then there's also a framework for developing or expanding existing training programs for a learning health system for researchers specifically to address healthcare delivery challenges. And that was this article on the bottom there by Forrest and team, developing research core competencies. In terms of the culture and competencies enabled dimension of the learning health system, obviously we recognize that a successful learning health system requires staff and external stakeholders to feel encouraged and comfortable to participate in learning, which we know as a registered nurse who's worked in a lot of hospitals, you know, it's hard to change the culture of an organization and how things work. And even within an organization, you have microcultures within each different part of a hospital or broader organization. And so we really felt that Indigenous cultural safety training should be mandatory for learning health system stakeholders to ensure all aspects of anti-Indigenous racism are addressed. OCRAP training, this goes back to some of the data frameworks that I previously presented. It really should be mandatory for those who make decisions, anyone who makes decisions around data, whether you're an analyzer and looking at the data and making decisions at that level, or where you're the CEO of a health service organization, or even at the government level providing funding. You know, this is OCAP training should be required by everybody. And training and knowledge translation is also necessary to apply current research evidence and quality improvement training to ensure that data quality improvement is upheld. And these trainings can be supported by awards such as the Canadian Institute for Health Research Health System Impact Fellowship Training Award, which I had the privilege of holding for 2 years as a postdoctoral fellow, which is how I got started at Women's College Hospital. And it is a great opportunity. I encourage everyone to encourage their fellows or trainees to apply it does provide that competency of embedded sort of health services research, which really gets people thinking outside of our sort of ivory tower and that environment, and how things work, being so separated from what we're studying on the ground. And finally, the evaluations and accountability. We looked at the frameworks, we looked at some of the trainings, and now this is evaluations and accountability, and to see what we found there. So from a data and evidence-driven perspective, we see that the learning health system requires quality real-time data, and data that reflects both patient perceptions of care received as well as clinical data and services and treatments provided. And it's imperative that the learning health system collects data about itself, not just about the patients, and about how the learning health system is operating. Yet the learning health system tends not to collect and synthesize this type of data. And we see this reflected in the lack of implementation literature on learning health system data systems. And the complexity of accessing and reusing data in a heterogeneous system and forms are barriers to data system implementation and evaluation efforts. So there could certainly be more done to sort of enable training for people to understand data systems more generally. So because it's always on the periphery of any other part of the learning health system, whether you're a data scientist or not. And patient-centeredness, we found no specific methodology for evaluating patient-centered care in a learning health system. But again, I mentioned this cultural systems change assessment tool that was developed in BC, the Northern Health Provincial Health Authority, the Northern Health Authority. And it has several evaluations with the potential to evaluate cultural safety in health systems. So, excuse me, so it can be used as well as a framework as well as a sort of an evaluation tool. And it is really critical from an Indigenous perspective to select tools that can be adapted to measure the characteristics and objectives of the patient-centered sort of component of the learning health system. And excuse me, and in terms of systems supported, the board governance of health system quality assessment tool. This was designed to identify and improve issues in board governance quality and effectiveness within a learning health system. And there's also a model for assessment of telemedicine framework, which measures the impact of learning health systems, focusing on domains of clinical effectiveness, organizational challenges, and social, cultural, ethical, and legal issues relating to health system governance. And then finally, there's a clinical performance sort of feedback intervention theory that sort of guides the creation, implementation, and evaluation of patient feedback to support system level decision-making. So a few other sort of resources on the system supported component. In terms of the cultural competencies enabled we recognize that the learning health system must be evaluated in collaboration with community populations and, if appropriate, clinicians to ensure accountability and equity. And the formerly Wellesley Institute, now the Paloma Wellesley Institute, they have developed an evaluation framework to assess program effectiveness, which examines equity, cultural accountability, and progress towards the objectives established. And Craft and team provided a combined strategy that duly emphasizes physician engagement and accountability for continued education. So this is a lot of information, I fully recognize. It really is a survey of the sort of resources that we found, but hopefully can be picked up. And if any of these resonated with anybody and you're interested in or currently thinking about learning health systems and wanted to use one of these resources, the paper that we published sets out some more details about each of these resources. And so we created for healthcare providers this accountability framework, and it really came out of sort of what we found in the literature around learning health systems and the resources that are available to develop and support them. And so we provide, this is just sort of, I just wanted to give you a sense of, I'm not going to go through all of these, but just to give you a sense of where that, this could be used as a tool for organizations, for health service organizations, or any organization thinking about learning health systems, or even if they're not even there thinking about learning health systems, it sort of raises quite a few issues about maybe what could be considered towards moving towards a learning health system. And so we've got sort of executive board and some recommendations looking at department directors, and data systems and infrastructure, patient-centeredness, how systems are supported, how culture and competency is enabled, and then of course, the learning health system as well. So it was sort of developed, to sort of, monitor the progress sort of over time. This is government, right? They wanted Ontario Health. They love these little checklists, so so that was the intention of this. And then in terms of and then we also produced a gap analysis recommendations for some of the pieces that we think could be further developed in terms of creating resources to develop a learning health system. So we've put some recommendations here for each of the components: data systems and infrastructure, patient-centered, system supported, culture and competencies enabled, and then of course the learning health system as a whole system. And that's it. I'll just stop sharing here.
Thank you so much, Tammy. That was a very informative talk. I think you've walked us through, so many examples of frameworks, but also of items that are really important to consider, especially as we're starting out and building, a learning health system here at Women's. And I also want to thank you for sharing some ideas of training, especially, at the organization level. I was just curious, because you mentioned things like fellowships. Do you have any other tips or ideas on more general training that folks institution-wide could consider taking? I mean, as you know, this seminar series, we've opened it up to everyone at the institution. And the reason I was looking at the participant list was not just for the numbers, but to see who's here. And I see that we're pretty well represented when I look at different names. So yeah, any kind of general, easily accessible kinds of trainings that you could share?
Yeah, I mean, I'll reiterate the OCAP training, which I believe is now accessible at Women's College Hospital. I was invited to take it. I have yet to take it, but I feel like I've had a crash course in it working with the 2 Indigenous teams, but I do want to take it. So OCAP is definitely a good one, and that's developed by the First Nations Governance, I think it's just First Nations Governance. They're an organization, an Indigenous organization in Ontario. And it really is it should be an essential training for anyone who deals with data. I've heard great things about it. And then of course there's Sanyas training. I mean, the problem with some of these trainings are, in order to make them so broadly accessible to so many people, you have to have ones that, a lot of people get behind. And so I think, Sanyas is great. I know people who have taken it. My husband's taken it. But I think I think it has its constraints in terms of appliedness, and it doesn't have health specific components to it. And so yeah, I mean, those are the 2 big ones, just because I know they can go to scale. I'm sure there's more out there that I'm not familiar with. But yeah, that's probably all I have to say on that.
Great, thank you. We have a question.
Actually, one thing I would, sorry, Sumit, just to add to that, one thing I would say is, I think while these trainings are really great, if there's something I've learned over the last 3 years of working in these spaces, is that, we can't just do these things one time. It's like a huge dump of information, and it's very hard to absorb it and apply it on a day-to-day basis when you do it and then it's gone, and then you don't have access to ongoing sort of maintenance of training. And I think that's a big piece that I'm sure people are thinking about with respect to Sanyas. But when we think about it from an organizational perspective, who should be taking training, who has access to it, is great, but also we need to be thinking about what next, because it's very easy. This is some of the stuff that comes up in Sanyas. There's a lot in there that a lot of Canadians don't know about. And it's, I've certainly learned a lot, and I've struggled to sort of sit with that information and what is my accountability to knowing that information now. And so I feel in many ways there is a responsibility for whoever's providing the information to give some more structure to not just saying, okay, this is on your, when we come to Women's, your onboarding training that we do, it's great. But I think something like this needs to be thought a little bit more carefully about how can we support that learning over the long term, because it can't just be all digested and then move on. It's not an applied type of knowledge. It's something that needs to inform our practice on a day-to-day basis.
Absolutely. Thank you for adding that. And I see that your colleague Nadia has also commented on offering certain trainings and workshops. So that's great. We're going to go to O'Neill and then Rulan.
So, Tammy, first off, thanks for that very broad overview of a wide range of frameworks. I'm curious, one of the recurring critiques of the framework is, it doesn't account for power imbalances and so forth. But if you took that framework and you applied it to a First Nations health authority that is operating its own health system from a sort of more managerial perspective, to what extent is it relevant to an organization that is autonomously managing the health of Indigenous people, in an Indigenous organization managing the health of Indigenous people?
Yeah, I mean, I guess it would be up to that Indigenous health authority to sort of consider that. I don't know. I feel as though I'm not sure if a learning health system, I shouldn't speak. I should let Nadia answer that question. But certainly, Indigenous people, the way they practice health and encourage health and promote health is done very differently. So something tells me that a learning health system might not be part of that. I don't know. That's just my guess. So I'm sorry, I don't have an answer for that.
I can help with that a little bit. I know that Indigenous communities all over Canada, but specifically, we'll talk about Ontario. Each community and governing body will have a portfolio for health that identifies their community's priorities for health and research. And that's always a good place to start. You'll hear us speak a lot about building relationships. So it's those priorities as driven by Indigenous communities and their leadership. Does that answer the question?
Well, the question is, is it appropriate to Indigenous leaders in the application and management oversight of their own health systems, so their own health organizations? Is there something missing from the Learning Health System framework that's sort of incomplete for its application within an Indigenous healthcare delivery system?
I think so. I think part of, as I was noticing, of course, this is Tammy's area of expertise, but it's the conversations really are about addressing the lens and perspectives. So even as we talk about successful outcomes, who is determining what those successful outcomes are? So within the frameworks themselves, there needs to be a consideration to understanding that these meanings and these definitions of progress, success, even community or whatever themes come up, that there's an understanding that those perspectives are diverse depending on who's interpreting them. So then those conversations need to be had. Yeah. So the frameworks, I would say, from my own experience of working in the realm of reconciliation, that I think we're only just starting to understand, and the frameworks don't quite reflect what we are talking about in terms of what that partnership as rights holders looks like, right? Who's speaking for who and how. And those power dynamics are certainly very important to consider as well.
Thank you, Nadia. Rulan.
Yeah, I have a couple of questions, but I think maybe if I could direct this question to Nadia, who just spoke. I want to know, and actually from not you, Nadia, and also Tammy, I think the diversity we have diversity within diversity. And so as we're trying to engage communities, we recognize that one person doesn't reflect all. How do we make sure that we capture that diversity within the Indigenous communities to make sure that we're not narrowly looking at it, but we're thinking a little bit broader?
My answer to that, and so for the work that I do, and then Tammy will offer, I think the supporting and complementary answer from her work, is that when we think of territory and when we, for example, the land acknowledgements that we do that because we're recognizing the diversity of land and community and nations and that kind of thing across Canada, right? So the question of diversity is that the frameworks themselves don't so much like the frameworks that are offered by community when engaging with community. So frameworks, I think, should offer a how rather than a what. So the process itself helps you to engage with any community in a respectful and meaningful way. It's never a checklist, and yes, each community will have their own approaches and governance structures and frameworks, but generally it's the way of approaching, which begins with that acknowledgement of where you are, that will then illuminate the process of engagement. So it's not so much the what, it's the how in these frameworks that is really, really important.
Okay, so just, I guess, thinking of it as that it's always iterative and constantly learning back. I like the term also learning health system communities. I thought that really, because we talk about, are we a learning health system? I can't remember what the version was we decided, but system infers it's the whole system, but communities are like, we're just one part of the larger community, right? So trying to identify how we identify ourselves. The question I wanted to ask Tammy was a fabulous overview, by the way, and really richly comprehensive about what we need to think about. As we're beginning this journey, were there areas that you think that there were clearly gaps, and everybody had gaps, not everybody addressed everything, but do you think there are areas that we should start working on that were sort of less, that might be easier to start with, that other people hadn't addressed yet, that we could then be unique in a specific area? Are there places that you think uniquely that we could contribute?
Yeah, I mean, my sense is that the data piece has really sort of taken off, and I understand that component has sort of had more resources put into it. I mean, we have to start with data. We can't tell, we have to have a baseline, so it makes sense. It's intuitive. But I feel like culture is a really challenging piece of a learning health system in any health system. Culture is a challenge of any organization. They say, strategy eats culture for breakfast. It's really hard to build and to maintain a certain culture within an organization. So, and women's, you have a very strong culture compared to other healthcare organizations. I would say that would be a great place to start. You know what it's like to focus on a certain value. And so that could be part of the culture. Obviously, a learning health system culture would look different than an equity culture, as women's has sort of crafted for itself. But I feel like that is probably one, because it's so difficult to build and maintain. I would say, but it's also required for every single other piece. So everyone has to be on board. We have to have these values of that requires a learning health system. So I would say that would be probably the most important piece.
That's a great segue for us, because we were hoping as we build these seminars that really the idea is that we're starting to talk about it and helping, continue the culture of learning. So thank you so much, Tammy.
Thank you, Tammy, and thank you everyone for joining. So Tammy and members of the LHS steering committee and senior executives, so we will be meeting. There's a separate Zoom link for the post-seminar chat. So please look for that in your calendars. See you soon. Bye.
Thanks, Tammy. Bye.